The COVID-19 pandemic has placed an unprecedented strain on healthcare systems around the world. The goal of this video is to enable you to find, assemble, and deploy critical airway equipment in the event that our respiratory therapist workforce is overwhelmed or unavailable. By the end of this video, you will be able to perform 5 critical tasks. Find and deploy a variety of oxygen delivery devices, prepare equipment for rapid sequence intubation, assemble the ventilator circuit, leak test the ventilator, and finally input patient-specific ventilator settings. Nasal prongs, TAVR masks, and non-rebreather masks are located inside all of our patient rooms in both the major and RAS areas. Oxygen flow rate should be set to a maximum of 6 liters per minute with nasal prongs and 15 liters per minute with TAVR and non-rebreather masks to help avoid aerosol generation. Venturi masks can be found on the point-of-care carts outside each room in major and RAS. Each valve will have the expected FiO2 and appropriate oxygen flow rate written right on them. The AirVo2 is a high-flow nasal cannula system which provides warm, humidified oxygen from 10 to 60 liters per minute. It can only be used in airborne isolation, and the plan is to store it near the RT cart in our department. The manufacturer's website has excellent instructional videos on its use. Bag valve masks are kept in a clear plastic bag in each patient room in major and RAS. They are stored with oxygen tubing, an antimicrobial filter, and a PEEP valve, all of which need to be attached before use, as we are demonstrating here. Oxygen flow rate for the bag valve mask should be set to a maximum of 15 liters per minute to help avoid aerosol generation. Rapid sequence intubation with video laryngoscopy is the standard of care for COVID-positive patients who require intubation. Rapid sequence intubation should involve a plan A, B, and C in the case of an unanticipated, difficult airway. Plan A involves video laryngoscopy. Our department has both a glide scope and a CMAC video laryngoscope. The glide scope is located in the hallway outside recess and has an attached airway bag with all the intubation equipment you'll need. The CMAC is in the supply area by the RT cart and also has an attached airway bag with similar equipment. The only real important difference between the glide scope and the CMAC in our department is that the glide scope uses hyperangulated blades while the CMAC uses regular geometry Macintosh blades. The glide scope has a disposable bronch attachment hanging on the stand as well. Choose whichever device you feel most comfortable with. Plan B for rapid sequence intubation involves a laryngeal mask airway. Our LMAs are stored in a kit in the 3rd drawer of the difficult airway cart outside recess 3. Use a size 3 for small adults, size 4 for normal sized adults, and a size 5 for very large adults. Plan C is a front of the neck airway or cricothyrotomy, and our fast cric kit is found in the bottom drawer of the cart. The ventilator and circuit should be prepared before intubation so the patient can be quickly placed on a closed circuit to limit aerosol generation. The equipment for the patient side of the circuit is in the airway bag stored on the video laryngoscopes. You will need, in order from the endotracheal tube to the ventilator, inline suction, corrugated tubing, an antimicrobial filter, and the end-tidal CO2 detector. The red key in the inline suction setup can be discarded. The antimicrobial filters in our department have changed a number of times, and they can be confusing. So to keep it simple, the white circular filters you find in the bag valve mask bag should only be used with the bag valve mask. The green circular filters found on the RT cart are being phased out as they are less effective when wet. They can only be used on the ventilator itself. And the square filters, which can be green or yellow and white, are found in the airway bags and can be used anywhere in the ventilator circuit or on the bag valve mask itself because they are still effective when wet. The airway bags are stocked with colorimetric end-tidal CO2 detectors, but if you prefer a continuous detector instead, the attachment can be found in a bin under the sink in recess 1. The lead from the detector is simply inserted into this port on the monitor and twisted clockwise until it stops. A waveform will automatically display on the monitor when it detects CO2. Now let's get to the ventilator. The model we have at Mount Sinai is the LTV-1200 and is stored in our supply area opposite the main desk. It just needs to be unplugged and wheeled back to the patient. The first thing you have to do is plug the ventilator back in. It has a battery that lasts 4 hours, but don't rely on it. Next, you will have to circuit the system. This just describes plugging the appropriate tubing and filter into the ventilator. The antimicrobial filter will insert into this port and connects to the main tubing, which can be found bagged in the same storage area you found the ventilator. You'll notice a lot of this tubing can't be plugged in the wrong way, as each side is a different size. There are 3 smaller tubes which attach here. One is white, one is yellow, and one clear, and the receptacles are color-coded to match. They also have a male, female, and simple push-on ports, so it's fairly impossible to insert them the wrong way. Insert them tightly. The thick white tubing from the left side of the ventilator is for oxygen delivery. If you have to use the attached oxygen tank, make sure it is full by looking at the dial. The oxygen flow should be set to auxiliary for use with the ventilator. However, with high FiO2 requirements, your tank won't last very long, so you must plug it into the oxygen port on the wall as soon as possible. It's a simple screw-on port, so if you do use the wall port, make sure you turn the O2 tank to off, as some gas will leak when on the auxiliary setting and you'll drain the tank. Once the ventilator is connected, a leak test is the next step. This is perhaps the most complicated task you'll perform, but we're going to walk you through it. First, press and hold the select button, and then the on/standby button at the same time. This will start the ventilator and allow you to enter the leak test mode. The machine will beep. Please take note of the silence button off to the right of the panel, which will be invaluable. Keep pressing select until the screen shows the word leak. Occlude the open end of the main tubing and press select one more time. This will start the test, which takes roughly 20 seconds. You'll notice that we've simulated a faulty circuit by unplugging one of the tubes from earlier. Our demo test has failed, and these faulty connections are the usual cause. Make sure everything is plugged in tightly and navigate the menu using the dial on the bottom right of the panel until you see the screen say leak again. Occlude the open end of the main tubing one more time and press select. If the system fails again, replace your circuit with a spare from our storage area and retest it. Any ventilator failing a leak test with a brand new circuit should not be used for patient care. You will need to call for help immediately and bag the patient. Now you can see the leak test has been passed. Using the dial, navigate to Exit in the menu and press Select. Navigate to Exit in the menu a second time and press Select. You will now see the text Same Patient. Congratulations, you have successfully leak tested your ventilator and managed to return to the initial screen for inputting patient settings. This was the most complicated process in our video, so let's review the basic steps one more time. Turn the ventilator on by holding Select and then On Standby at the same time. Keep pressing Select until you see Leak on the screen. Occlude the circuit and press Select again. If the system fails, plug everything in and try again. If the system passes, navigate to Exit with the dial and press Select, and then do it again to return to the main menu. The ventilator is now simply asking you to describe your patient before setting the parameters it needs to breathe for them. Once you see Same Patient on the monitor, use the dial to scroll to New Patient, and then press the Select button. It will say Infant. Use the same dial to rotate past Infant and Pediatric to Adult, and then press Select. You are now ready to set the vent. Emergency department, respiratory therapy, and ICU leadership have collaborated on simplified initial settings which will work for the majority of COVID-positive patients intubated in our emergency department. Patients will be ventilated using volume assist control. You can choose this setting using the 2 buttons at the bottom of the panel. To change this setting, the button must be pushed twice. Once volume assist control is chosen, the settings you can alter light up on the panel. Pressure values, however, will stay dark, as they are not variables you can manually set in a ventilator operating on volume control. Let's input our values from left to right on the ventilator. Breath rate is the first setting on the left. Press the button and use the dial on the right to change the value. Press the breath rate button again to confirm. We have chosen a breath rate of 20 breaths per minute for COVID-positive patients with previously normal lungs. Patients with a history of obstructive lung disease should start with a rate of 10 breaths per minute to allow them greater time to expire. These patients do very poorly on a ventilator, and you should call for help immediately after intubation, emphasizing their underlying lung disease. Tidal volume is the second setting. It will be based on a calculation involving patient height, which is used to determine ideal body weight. A measuring tape will be available in the room, and a chart with the corresponding tidal volume will be posted to keep things as simple as possible. We've chosen 6 cc's per kilogram as a safe starting point and have eliminated gender as a variable to reduce cognitive overload. Inspiratory time can be set to 1 second. FiO2 can initially be set to 100%. And PEEP can be set to 5 centimeters of water. These initial settings should buy you some time to call for help. They will almost certainly need to be titrated, but are a safe and effective starting point. The ventilator should start immediately after inputting these settings. All that's left is to connect the circuit to the patient. Observe the patient's O2 saturation and end-tidal CO2 for a few minutes to confirm everything is working as expected. Also be sure to watch for hypotension with the onset of positive pressure ventilation. Once the patient is stable, you can exit the room. You should now be able to find and assemble the O2 delivery devices available in our department, collect the equipment required for rapid sequence intubation, circuit and leak test a ventilator, and input initial settings for a critically ill COVID-positive patient. Good luck and stay safe.